approach to altered mentation in a multiple sclerosis with ANCA vasculitis patient. This is about a 41-year-old female who came in with a past history of multiple sclerosis as well as end-stage renal disease on peritoneal dialysis, who came into the ED with a chief complaint of generalized seizures lasting more than a minute after her undergoing her peritoneal dialysis at home. On admission, she was with a GCS score of 6 and required immediate intubation and admission into the critical care unit. She was previously admitted a week prior with a similar episode and was discharged with expectations to follow up with her nephrologist and neurologist outpatient. While in the critical care unit, she was treated with Keppra, Vimpat, Depakote, and underwent several diagnostic imaging, including MRI, which showed moderate generalized cortical volume loss, which is accurate with her age, as well as diffuse white matter T2 flare hyperintensity, which could be correlated with small vessel ischemic changes or demyelinating disease. It also showed numerous scattered T1 hypodensities, which could reflect chronic demyelinating plaques and or chronic lacunar infarcts. While she was admitted into the critical care unit, she was also being treated for her end-stage renal disease with the peritoneal dialysis. Despite all the treatment with the secondary preventative medications, as well as the Depakote, the Keppra, the Vimpat, there was no clinical improvement, as well as no improvement in her neurological status. Of note, she was treated 6 months prior with rituximab and plasmapheresis. However, she was a candidate for a renal transplant and was off immunosuppressive therapy because of that. So 6 months prior to admission, she had not been on immunosuppressive therapy. So because of her worsening clinical status, a trial of stress dose steroids was done, as well as a dose of rituximab. After she tried these medications, her clinical and neurological status improved significantly to the point that she was able to be discharged with hopes of following up with her nephrologist and the neurologist on an outpatient status. Some complications that were found with this patient was a ventilator-associated pneumonia, which was treated with antibiotics, as well as a TSH level of 170, which will be followed up outpatient with her primary doctor via the levothyroxine. So the cause of all this is really in the question of, was it multiple sclerosis exacerbated by an infection, or could it have been a progression of her ANCA vasculitis progressing into the CNS? So based on several research articles, it is seen that CNS vasculitis, that is ANCA vasculitis, has been associated with seizure activities. It's been associated with many different symptoms, such as like posterior vertebral encephalopathy, hypophysitis, and cerebrovascular events. And so we believe that this patient just had ANCA vasculitis progression. And so the importance of this case is basically to show how the use of a broad systems-based approach to treating the symptom of seizures was able to allow us to treat effectively, as well as collaborate within the different specialties. And so this is our hope for the future, for all future patients, is to work collaboratively with all other specialties in order to find a solution that is effective for our patients.